it's really my pleasure to welcome two very distinguished women who are leaders and experts. One thing I want to say about Gloria's background that I wasn't aware of is that she spent a lot of years as a pharmacist working in a primary care practice. So she has experience on the provider side, but if you look her up, you'll see that a lot of what she did in the last few years was with the Employers Forum in Indiana, which is to say, looking at the cost from the payer side. So I think that's just very interesting. We're glad to have you here. There's more you can look up, but Indiana, for those who don't know, has been really doing a lot of groundbreaking work, both on the policy side, looking at prices, looking at price transparency, and a number of other initiatives, and she has been central to most of them, I suspect. For local folks, I think Kate needs no real additional introduction, but let me just point out...
I'm back.
Yeah. But let me just point out that having served as Secretary of Health, she does have a current gig. She's a member of the gig economy, but this is for the governor, and she's working on a healthcare affordability task force. So I don't think we have a lot of press in the room, but if you wanted to break any news here today, we'd more than welcome it. But also, that always goes well. But also, she, as many of you will know, she was CEO of Boston Medical Center and was at the Brigham before that. So I think we have really rich experience our way. So I'm excited. So I'm going to just start off with a few kind of open-ended questions. Maybe I'll just start with you, Gloria, first. What's the healthcare landscape in your state? The big players, the key issues. And let me throw in the follow-up right away, which is, given that landscape, what levers have you found to help bring healthcare costs down?
Well, first, thank you so much for having me here. I always love a direct flight, so really enjoy coming to Boston from Indianapolis this morning and then heading out this evening. Massachusetts has been doing such great work for many years. And in Indiana, the current landscape is we have an affordability problem. Healthcare costs are way too high. We have so many Hoosiers, which are folks that live in Indiana, in medical debt, higher than the national average. Our hospital prices, not the physician prices, but the hospital prices consistently have been in the top 10 year after year and in the country. And then our physician prices are in the bottom 10. So when I was hearing the prior panel talk about how we need to pay physicians more, certainly in our state, we do. We're not even at the national average. And that sets us up for what we currently have, which is a lot of, first we had horizontal integration, right, where the hospitals were buying out all the other hospitals. And now we have tons of vertical integration, where the systems have now purchased the whole vertical. So the hospital systems now own the physician groups and labs and imaging centers and infusion clinics, et cetera. And now we have insurance companies, which have bought PBMs and then now sit on top of all of that. And now they also own pharmaceutical manufacturers. So now they own literally every aspect of it. And that's a problem that we feel directly every day. And so I'd say affordability, access to care, transparency, wellness, prevention, all these things that have been discussed today are issues for us that we're actively working on. Your second question is, what are we doing? We've been at it for a few years now. And I would say when I was a president and CEO of the Employers Forum of Indiana, really grassroots, trying to find allies, reading all of the data, much of your all's research, using the data. But data alone is not going to, and probably nobody knows that better than Massachusetts, data alone is not going to get the job done. You need to have allies that are politically influential, and then you need to have where policy meets politics, that's what you're getting across the finish line. So that politics part's been really interesting. So when I got on the politics side of things, that's my first time in government. I've been in this role 15 months. Just by way of background, I have 6 agencies underneath me. So Family and Social Services Administration, which is primarily Medicaid, the Department of Health, Department of Child Services, which is primarily foster care, Department of Veterans Affairs, and 2 smaller disability agencies, about $31 billion in spend. So I should say not spend, budgeted. So our spend right now is a little bit more, and we need to, we're working on that, on reducing that, and we can talk about that if you're interested. So what have we been doing about affordability? There's no one magic bullet, otherwise everyone would have done it. So I took the liberty of just writing things down. So direct-to-employer contract was brought up. We actually put it in statute in 2025 that the hospital systems, the nonprofits, have to offer a direct-to-employer option to any employer, and it has to be less than 260% of Medicare. Now, that number may be very high for some states, but for us, when our average is 300% of Medicare, is actually a pretty good deal. And it's just, and this is really important because, price, I've done a lot of price transparency work, and price can be sliced and defined 9 different ways. So this is hospital facility prices, does not include professional fees. Because again, I told you our professional fees are really low, right? And our facility prices are really high. So if you melded them together or didn't clearly define what price meant in statute, it'd be a problem. And we have run into that. So I would say that's low-hanging fruit. We had it's shocking. Hospitals want direct-to-employer. They do. They don't want to deal with the insurance companies. And the employers want to deal with the providers directly. They get a much better deal. Like if an insurance company has negotiated 400% of Medicare, are they really trying that hard? So many of them are getting under 200% of Medicare for inpatient services and outpatient services. Site neutral payments is another affordability opportunity. We got that across the finish line. You never get everything that you want right off the bat. There's always this negotiation and dance, and sometimes you have to come back the next year or the following year and do some cleanup. So we passed it in 2023. At the very end, the industry is they have always outnumber us, always have hundreds of lobbyists. They got things put in like, oh yeah, we'll be happy to do X, Y, and Z, but then, start changing definitions and striking out words. So what we have now is site neutral payments just for services that are off campus. So this got to, how we were saying, it was an independent primary care office, health system purchased it, and so now they tacked on a facility fee. So the patient now gets 2 bills. They get the professional fee, which is what they were getting, and now they get the hospital facility fee, and prices go up. And there are folks in the room here that can kind of talk to the range of prices going up. So we said no more. If you are more than 250 yards away, which is off campus, you can't charge a facility fee. And that's been great. There were some other shenanigans. We kind of clamped down on those. I didn't think this was going to be any big deal, but fiduciary responsibility, requiring the TPAs and the PBMs to have fiduciary responsibility, you would have thought we were stealing their children. I really don't know what to say why that's a big deal, because they all, during testimony, say, we always do what's been the best interest of our clients. I'm like, great. Well, that's what a fiduciary is. So what's your problem? And they couldn't defend it. And really, legislators were fine. They were like, you say that's what you're doing. And if you're not doing anything wrong, and it protects employers, because if employers get sued by their employees for not doing what's in the best interest of the employees, and that goes back to investment law, then they can turn around and sue their PBM and turn around and sue their TPAs, because they're the ones managing the formulary and putting in all of these prior auths and whatnot. Patient cost sharing, another one you really wouldn't think would be that big of a deal, and not all employers were on board with this one. So I'll share it with you. It's brand new for us. This is if you can shop for care and you find a better price. It's kind of like the GoodRx model, right? You're like, why is it that without my insurance, I can get the drug using GoodRx or Mark Cuban Cost Plus or whatever cheaper than if I use my insurance, right? So, but you can now go on Amazon and go find a boot for yourself, right? That might be a lot cheaper than going to the DME store in the hospital or even in an independent. So as long as you know what you're getting, it's medically necessary. So now it has to be applied towards your cost sharing. Okay, so for people that will shop for care, it can be applied. And audits, you would not believe the restrictions that are typically in contracts for audits. So we just open that widely. And probably one thing that many of you may have heard is we're doing state average commercial pricing for our big 5 hospitals. And if they don't get basically to the state average by 2029, they are not going to be state tax exempt anymore. So it's not a cap and it's not a ceiling. We're letting them voluntarily lower their prices, but if they continue to act like a for-profit, then they should pay taxes like a for-profit. And so that's the opportunity there. It only applies to the largest ones, not all of them. And I'll just leave with the last one. It's really important. It's kind of segues off of what we just heard, is we have to increase competition. We don't have primary care providers in Indiana. They are all swallowed up by the bigs, the big hospital systems. Private equity, has come up and eaten up a bunch of our physician groups. So it was just imperative that we ban physician non-competes, banned them. Took us a couple years. First we got primary cares done, and now we have them all done. That's really important because not only can they not, these were like 50 miles in 5 years. Imagine the docs contracts for 2 years, and then after the contract is up, they cannot work within 50 miles for 5 years of any hospital that hospital system owns. So we were pushing our own doctors out of state. Ridiculous. And it really hurts the rural areas the most. Anti-competitive contract language. We offer physician tax credits if they'll start up an independent one, and we offer provisional credentialing. So those are just some top highlights, and I bet you're sorry you asked me.
Great. So, Kate, 25 years ago, Massachusetts did some groundbreaking work, and we have a lot to show for it, but it's a very different landscape now. And you just recently were Secretary of Health, and now the governor wants you to talk about affordability with your task force. So what's really kind of the hot button areas here in Massachusetts? And maybe you want to also react to what you just heard about what's happening in Indiana. Is Massachusetts ahead, behind? Where are we going?
Well, the sentence that really resonated with me is, data is not a problem in our state. We have so much of it, and we use it to make no progress. And so I think that's, I think that's probably, because everybody can find their shred of information and cling to it to say, this is why we're right. And so one of the things that the governor's working group on affordability is trying to break through is exactly that phenomenon that, the insurers point to the hospitals and talk about an arms race with AI-driven coding or, pick your topic. So I think that one of the things we realize is that the answer is not in more information, but in actually just common purpose to, everyone could get behind access for all, Romney care, whatever you want to call it, precursor to Obamacare. It's been a lot harder to get people to think about how we pay for less. I think that was also what I meant of the hardest thing is to say no, is to not do something. I think for us in Massachusetts, the anatomy is pretty similar. The secretary is responsible for 11 agencies and Mass Health. It's about the state budget is about 60 billion. Our agencies are 31 billion plus, 20 billion of that is Medicaid. So one of the things I think the Affordability Task Force is working at is using the purchasing resides within the Medicaid program that would help all of us. One example, you spend about $7 on primary care. OECD countries spend about 15 cents on the dollar. Can we get to 10? And can the commercial insurers come along? Those are the kinds of things. Of course, as the prior panel said, what don't we pay for if we make those moves? I think there's a real opportunity in simplifying all of the friction and transaction costs that happen across our agency. I'm very struck by the fact that a lot of people across our state, our agency touched 1 in 3 people in Massachusetts. Massachusetts is a state of 7 million people. It's a relatively well-off state. Yet you are standing in line in the grocery store behind people who are buying their food with hopefully with SNAP benefits. If 1 in 3 people in the state need the kind of health and human services we're offering, how can we do that in a more efficient, effective way? The technical term for it is integrated eligibility and enrollment, but that's something that rests upon a system that is 30 years old. Somebody described it as dry spaghetti, that if you went in to try to unnest it, you just break off pieces of spaghetti as opposed to fixing this system. So here we have a system of health and human services that we're very proud of in the state. We have relatively good health outcomes, but it's at a cost we cannot afford. And it's driving up things that the rest of the state needs, that everybody in the state needs. Better transportation, better public schools, better public safety, and the real bugaboo in our state housing. And so how do you take the dollars that are there, and how many people are actively engaged with our health system because they can't get a job, their housing's unstable? Like all the things that are, when I worked at BMC, I used to talk about, we criminalize certain diseases, behavioral health and substance use disorder, or we medicalize poverty. And I think a lot of what we see in our state is the medicalization of other government-sponsored resources that just aren't working for people, whether kids aren't getting educated or you can't find a home or a roof over your head. That ends up on the healthcare system, which is part of what's driving these costs. So for us, and I'll stop in a second, but for us, I think in Massachusetts, we look to states like Indiana, like Arizona, that maybe haven't had as long a history of providing these services through the state to say, how can we do it better? Because a lot of what we're going to have to do is change how we provide these services and where we provide them. And, nothing's harder to close than a hospital except a state facility. And so as we think about these changes that are on us and how the technology's enabled all of us to do our work better, how can we use those to benefit the people we serve?
Follow-up for both of you, unscripted, but it just strikes me that this would be something to focus on, and that is, excuse me, when you think about what you could do sitting at the state, there's kind of like 2 buckets. One bucket you've talked about a fair bit, Kate, which is the state as purchaser of health, running a Medicaid program, etc. The other is the state as regulator. And so I heard a lot from Gloria about state as regulator, not that much about state as purchaser. And I heard a lot about state as purchaser from you, Kate, less about state as regulator.
I was the world's worst regulator. But so that's a very astute observation.
But go ahead, just go for it and tell us, what is there on the table that's not being used that could and should be used?
I actually don't think regulation's the way. I mean, I think we've got lots. I guess there's 2 schools of thought. There are people who say, with all that data has been created by state-funded commissions that are, we tax health system to create the Health Policy Commission to tell us that Medicaid rates are too low. I could have told you that. And so I wonder about the benefit of a state of state regulation to create the change that we need to see in the market. I haven't seen it work in Massachusetts because, to the point that Gloria made, the politicalization of the policy, which just becomes you just can't move in either direction. It's like you're in amber. It's like you're a fossil. And so how can you, as the secretary, make a policy move that is right, and then you spend all your time trying to figure out which stakeholders, many of whom are in this room, will be offended by said change. And how do you, and I think that really is just really challenging. I mean, I've had people say to me, in all earnestness, our agency serves left-handed kids with autism in the Blackstone Valley. I serve the right-handed kids in the Blackstone Valley. I'm like, can't you guys shake hands? Oh, no. It's a very different market.
So what I've learned here is Kate's way nicer than me because she cares what people think and doesn't want to hurt everyone's feelings. I don't care about that because my job is to really do what's best for our Hoosiers. Joking aside, I will say that you're right. Politics is, without the politics, you're just not going to get sound policy across the finish line. And I think that while our politics are different, the math is the same. I also just realized that our states are very similar. We're 7 million people as well. We spend about the same amount of money on Medicaid. Actually, we're spending more. I saw a KFF article where we're spending 9th highest on Medicaid, though if you talk to every other provider, they would disagree. And so, the data is really helpful to have. So you asked, what are we doing kind of at the state level? We've just got approved a couple of weeks ago. So Medicaid is a Mother May I program. You say, I have an idea, and then you write out a proposal and you send it to CMS, and they say no. Or they say, yeah, you can do that. So you don't just do stuff, you ask permission, and then you can do stuff. So I don't know, there's a provider tax called hospital assessment fee, and oftentimes pays for Medicaid. We did a couple of things. The big thing is how are we going to spend it? How are we going to spend the money that, it's money laundering. It really is. People can be critical of it. I agree. We shouldn't be doing it, but everyone does it. I don't know how we got here. But anyways, we take money from the hospitals. We leverage that money at the state level. We get more money from the feds, and we pay for Medicaid, and then we give the money back to them. So that's why there's a lot of criticism about this model. And H.R. 1, the One Big Beautiful Bill Act, it's getting kind of tapered down. It's up at max 6%, and then by 2031, everyone will just be at 3.5%. So what we're doing is rural hospitals are really important to us, and they're closing left and right. We have had so many OB services close in our state, and it's just terrible. We've had 15 closed just since 2020. So I think, gosh, we're like in another 6 years, if we have another 15 closed. I mean, I have a map of the state and drive times, so like what's the 30-minute drive time from anybody that can deliver a baby? What's the 45? It's tons of white space. So this is like a priority area, and it's important to keep not just the rural hospitals open. I need the birthing centers. We need a whole entire strategy around birthing. So we are thinking about paying it differently. And so that the way we used to pay it using one formula, and now we pay it based on a couple of things. What type of facility you are? Are you critical access hospital, rural hospital? Are you a big hospital, if you will? And then we also look at services. So they're going to get paid different amounts. Not everyone's going to get paid the same way. And we have basically a sliding scale, if you will. And part of it's tied to their commercial prices. So again, this is an opportunity for affordability. If you have really high commercial prices, you get paid less on Medicaid. But if you will do your job and lower your commercial prices, we'll pay you more on Medicaid, which is what the providers want. The hospital systems are like, they say we have to cost shift to commercial because you pay 57 cents on the dollar. And it's like some old AMA thing. And so now I have all their claims. And by statute, we had to pay 100% of Medicare anyways. I don't know why they keep saying that. But we are doing a full analysis on that at the claims level just to put that narrative to bed. But and we're doing stuff with the state employee health plan as well. That's like an innovation lab.
Great. A lot going on there. So let's move to questions. And I see someone right there, Paul Haddis.
So I'm Paul Haddis. I'm a senior fellow with the Lown Institute. I'm not here just by accident. I think Vikas thought maybe I want to ask something to help get things going and get the rest of you to join in. But I'm struck a little bit about what I heard, so I'm going to modify what I was going to ask, which was more or less, gee, when you live between the intersection of policy and politics as a secretary or former secretary, or even, quite frankly, you probably don't escape that, Kate, now as the co-chair of the working group, how do you balance different interests? But I want to modify it in this way. Secretary Sachdev, sitting here as a Massachusetts resident in a state totally controlled by Democrats, and you sit as secretary in a state totally controlled legislatively and the governed by Republicans, it was striking to hear you talk about your laundry list of focus and accomplishments, which sounded like a consumer advocate being placed in the job of the health secretary, and really in an incredible way when you look at the laundry list and taking on different interests. If you look at hospitals or the employers in Indiana, 5 of the top 10 are hospital systems. So my question to you is, how do you have the kind of list that you have with the kind of potential pushback that you get, or maybe you're not getting, from those kinds of interests who often have strong power? And for Kate, I'll pick up on your one comment where you said the hardest thing probably is to close a public institution. Maybe second behind that is a smaller hospital. But how did you, when you were secretary, balance both the interest between potentially smaller, ailing and failing institutions and larger ones, which often, project rightfully or not that they are important places for job growth in the economy? How do you balance their interests versus the populace overall in terms of access and affordability? So slightly different.
I get some time to think. Okay. That's a great question. Where did this all start? How did we get here? We were nowhere in 2020. So 2020, I went to the State House as president and CEO of the Employers Forum of Indiana. Nobody knew me. My first time testifying there. And I talked about the RAND, Hospital Price Transparency Study, that I held the MOU for the whole country, and came up with the design and contracted with them for. And I was like, I think we have a problem here, because we only had done 25 states. And the president of Anthem Blue Cross Blue Shield at the time came up to me and goes, Gloria, nobody thinks you're going to do anything about it. Nobody cares. And the hospitals are too powerful. The hospital association's too powerful. Nothing's going to change. That's the exact wrong thing to tell me. And so we spent the next 5 years doing more studies. Harvard did a study looking at the RAND and validating it. And just more, a lot of research came out in the space. And so we had the data. And then there were like 100 lobbyists, and they were criticizing everything. Criticizing me, criticizing the forum, calling up all the employer CEOs that were members, telling them how terrible I was and that they should quit. It was ugly. And it's been ugly ever since. So to say that it's all kumbaya and everyone's going to get along, really just DTE was like that, direct to employer. Everything else has been brutal. And every year I'm like, I'm not doing this. I'm going to retire. But I want to tell you, it's so worth it. I do sound like a consumer advocate, but I was that poor student, in college. I had no money. I had no health insurance. I took the bus to go wait tables. I put myself through college, and I had medical debt. Took me, I went to school on campus, primary care. They sent me to a cardiologist. I didn't know anything, but I just assumed it was with the school. It was private cardiology. It took me 7 years to pay off that bill at $10. Wasn't even that much in today's terms, but for a broke student, and so I feel that. I think that's where all my passion comes from, is I was that, and I feel it, and it's a worse problem today, and it's a growing problem. Where are people going to deliver babies, right? So I'm very passionate about this space, and I'm not going to stop.
Thank you. I actually think there are far more commonalities than differences, and I think it comes back to the fundamental reality, which is the states have to balance their budgets, and the federal government doesn't. And so I think what you're hearing in common themes from both of us in a very blue state, and I don't know how red you guys are, but, Yeah, is that the budget forces the budget realities force decisions, and when you look at the set of decisions in front of you, you end up with a very similar set of policy options. And I would say in this state, healthcare is a huge employer. So are life sciences. And if you look at medical trend and you look at the cost of medicines and you look at what just walk around Kendall Square. I mean, I worked here longer than I care to admit, probably 20 years ago, and there was nothing. I mean, Novartis had converted the Necco factory into a lab, and that was the first building on the street, and now you can see with your eye as you walk around. And so the state is balancing the economic imperatives to grow the state economy. In our state, we grow with innovation, and that creates, I don't even want to predict what Lily's done to your state, or for your state, but so that we have a very similar set of challenges, which is why closures are really difficult. Changes in programs are hard. That's why the politics of the policy initiatives really become, as secretaries didn't spend enough time there. I underestimated how challenging they were going to be. So as you guys think about changing the system that you love, and you're stuck in this room on a beautiful spring day, like what is it you want to do to try to change this? Don't underestimate the fact that there are people's livelihoods depending on doing exactly the wrong thing. And how do you bring that across? As you say, pull it over the finish line.
Yeah, so I agree. I just want to be really clear that this wouldn't happen without our governor. And the reason is he had a bipartisan bill when he was a senator, Governor Mike Braun, who's the governor of Indiana now. But when he was a senator, right before coming here, he had a bill with Bernie Sanders. Imagine these two having an agreement on how to address healthcare. It was all on transparency. So because he's very knowledgeable about the shenanigans and the games and saw all of the battles, if you will, in DC, he came here and he's just like, you're the CEO of healthcare, fix it. And so without that, I would not be able to do anything. He's able to pull all of the legislators into his office, and say, this is really important, let's get this done. And then we have this massive team that goes and just educates people about, you have to educate so many legislators. And you only get maybe 5 or 10 minutes, and then again, the lobbyists are coming in. So that I cannot emphasize enough how the politics is equally as important as the policies.
Great. Jean Lambrou, Century Foundation, and I want to go back a little bit to the pointing of fingers that happens a lot. What we hear when we talk to the public is, well, hospitals are there, they're important, they're parts of our community, but the real problem is the insurance companies and the drug companies, and what are you, state officials, going to do about that? And I know you talked a little bit about your copay policy, but we'd love to hear a little bit more, both about how you address the concerns, the real problems, as well as a public perception that all the money is going to the greedy drug companies and insurance companies. Thank you.
Yeah, so every session, the PBMs are pointing their fingers at the pharmaceutical companies, and the pharmaceutical companies blame the PBMs, and every year the hospitals blame the insurance companies, and the insurance companies blame the hospitals. That's just the dance they play. Everyone's confused, nothing gets done, right? So you have to, again, have a lot of, basically people were saying we were picking on the hospitals. So stop doing that, Gloria, and start working on insurance stuff. So I'm like, okay. And so, again, politically, that's what we needed to do, is balance everything out. So we came out with very strong PBM bills, very strong insurance bills. We're going to come in this coming session with more, not letting up on the hospitals. We talk about the cost of healthcare. It's not the utilization, it's the price of healthcare, right? So price times utilization is cost, right? Price times utilization is cost. We have a price problem. So our focus is price across the board. Manufacturer, like all of them. You just start saying something to a manufacturer, and then all of a sudden you have direct-to-consumer opportunities. I was working with some drug manufacturers saying, why do we have to go through the PBM to begin with? We have direct-to-employer on the medical side. Why can't we have direct-to-employer on the pharmaceutical side? Yeah, we get the rebate, and you're right, this was on the state employee health plan side. Yep, so state employee health plan is just like any other commercial payer, but we are looking at some innovations We're not doing 340B through our managed care entities anymore starting July 1st. So we'll save about $20 million. It's not a huge amount of money, but it's definitely worth the squeeze.
You want to say something? Go ahead.
I'm short. Okay. Hi, my name is Hannah Sarni. I'm a registered nurse. and I'll be a nurse practitioner in a couple of years. I'm from Framingham, Massachusetts, and I work in Worcester at UMass University, do renal and liver transplants. So something that I found interesting when you guys were speaking, Ms. Walsh, you mentioned that we medicalize poverty. And I see a lot of that where I work, and it just made me think, and I would love to hear your perspectives on this, how much of our healthcare expenses and our costs are due to a lack of funding in public health, specifically like our schools, food, housing, all of those things, and how would it change or affect affordability if, for patients with an increased investment in these services? So, thank you.
Yeah, I don't have a number, but there was a study done by Betsy Bradley, and I'm blocking the other person's name, that looked at healthcare spending and outcomes in Massachusetts, comparing it to the top 10 OECD countries. But when you normalized it for public health spending, our outcomes were in the U.S. I think we were like 15th or something. We didn't make the public health investments, but when you took I'll pick on Switzerland. If you take the health spend in Switzerland, add together the social spending in Switzerland, and look at where their outcomes are, that's what actually drives their better outcomes. And I think that work's been well understood, but it's very hard to change the politics and the policy to actually get us there, because you end up with a whole lot. I mean, just look at look at the dialogue we've had in this country around SNAP benefits. SNAP is $1.60 or $1.90, I can't remember, per meal. I don't know what you can get for $1.90. I don't know what you can get per meal in Indiana on that. This is not, it runs through USAID. Yeah, through agriculture. USAID exists no more. But it is the most convoluted program. We have people sitting in offices in Worcester who can't sign somebody up for SNAP benefits, even though they have all the information, because they are not federally certified to do that work. It's crazy. And again, when all the stuff is done, it's $1.60 per person per meal. That's not going to feed anybody. And that's just one good example. Look at surgical outcomes after when somebody's poorly nourished. It's just, we see it again and again, and we're unable to make these changes. And, I ran a health system that was sort of devoted to making those changes, and we were able to do some of it, but all the incentives go in the other way. No matter, what I did at Boston Medical Center, we had prescriptions for food, a food pantry, it still mattered how many hips and knees we replaced.
Thank you.
Thank you. Do we have another question? You have no idea how much self-discipline I'm exercising, because I would love to get into this.
Hi, I'm Jessica Curtis. I'm a consultant with Undo Medical Debt, and before that spent 12 years as a consumer advocate at Community Catalyst, and delivered my first son at Boston Medical Center. So thanks for all you did, Kate. But I'm actually here as a parent of a kid with a physical disability, because I hear this conversation around the politicization of policymaking, and I'm also trained as an attorney, and I will tell you I have needed every year of my education, both in law school and as an advocate, as his mother. And just the time I've spent getting on the phone, figuring out bills, et cetera, et cetera. But people with disabilities and their caregivers do not have the time and are often not invited or don't have the capacity to be in these rooms where these decisions are happening. So I would love to hear from both of you, where have you found opportunities to include people with disabilities? Because I feel like in that particular community right now, what we're reading is the narrowing of options for care. Those are the choices that are going to get made, and those are some of the services that are going to be cut. So could you talk a little bit about where you actually see hope and opportunities for patient voice, particularly for the disability community?
So first, I love Undo Medical Debt. So that's such a great organization. For those of you who don't know who they are, they buy up medical debt, and then they do a lot of fundraising, and then they pay it off for people. So, and it's 100 to 1. So you pay off, you donate $1, you pay off $100. So I don't know, I'm just a big fan. I know you've done stuff around the country. Now, to answer your question, we have, as far as HOPE goes, I have 2 disability agencies, 2 smaller disability agencies, but even within our other agencies, this vertical is new for Indiana, where in many states they've had it forever, but this is the first time it's been around. So we are sharing data, sharing information, including from our disabilities. Like how many of our patients, I'll just one example, how many patients who have disabilities are veterans, because I have the Departments of Veterans Affairs, and they have tons of benefits for veterans and their families. All the kids can go to college for free, so if you can just identify who the veterans are in this population, that's helpful. And same with Medicaid. Most of them are already on Medicaid, but not all of them, but there's still certain services that can be covered. We also have a Department of Health where we have women, infant, children. We have a lot of opportunities there, and we do a lot of hiring of folks with disabilities.
I think it's a really big problem, and I really appreciate the work you do in calling it out. For me, nothing was more challenging when I was secretary, and we had a lot of challenges when somebody had a flat tire in their wheelchair. You may or may not know this, but there are 2 private equity companies that have rolled up wheelchairs in this entire, and these wheelchairs are enormously expensive. What we did in Massachusetts, and I encourage you to go see it. It's out in Worcester. It's this like building where we basically have figured out how to fix wheelchairs ourselves. And you walk into it's like a bike shop, and it's like it's a bunch of guys, you think they rolled up on their skateboards. And they are so proud of how they kind of can trick out wheelchairs to maintain people's independence. But God forbid one of them gets a flat tire. A flat tire can keep you in your house if you have a disability in our country and here in Massachusetts for 3 months. I mean, it's just astounding that we have all this technology. We all walk around with a computer in our pocket, and we can't get a flat tire fixed on a wheelchair. And so I think calling out the issues, we actually worked with one of those companies and basically put them on retainer so that our patients wouldn't wait so long. That was an expensive fix, but the only one we could come up with because there was literally a monopoly. There is so much and I think even what you described in Indiana, it's the same in Massachusetts. Well, there's a pocket of services here, and if you know this is a pocket of services here, but we expect the families to navigate this. Maybe Claude can navigate this for us, or or ChatGPT or something. But it's kind of crazy what we put families through and what families have to learn to care for their loved one, and I think we also. I read a book once it was called The Invisible Minority, and that it's people with disabilities, and that was like 20 years ago, and that minority is becoming larger because people are living much longer with disabilities. So how do we build a policy environment that is welcoming, inclusive, and empowering to these patients? And I think we're getting there, but it is not perfect, as you know from living in the state.
So we are out of time. Is there one last question? I think we'll hear the question. We may not hear all the answers, but let's go.
It's not so much a question. First of all, my name is Sheila Evji, former retired CNO, and I think you've all done a great job, but one of the areas that I am not hearing about is how is the patient being empowered to do what is best for their own health? I mean, GLP, somebody mentioned the cost of GLP drugs, it's ridiculous. So what are we doing to try and turn that tide around and place some of the responsibility on the shoulders of the patient.
Thank you.
I would just caution against some of that dialogue. The way I experienced it when I was in government was the so-called, quote, able-bodied people. And that rationale was used as an excuse, as far as I'm concerned, to remove people from benefits. I use the example in Georgia where they instituted work requirements. So the average, able-bodied single man in Georgia cost the Medicaid program $5,000 a year. The work requirements cost $12,000, and so like $1,000, not dollars. And so I think we have to be careful about how that rhetoric is used. I think patient empowerment is the key to. We were talking about unnecessary medical stuff in the or what is it, low value medical care. We were talking about that. I think that's absolutely where it should be. But from a policy perspective, it's just so easy to villainize a group of patients because they haven't been able to, their lives are disorganized, or they're working in a gig economy and they don't have insurance. That's my personal. You can disagree. Go ahead.
Well, I might disagree. And so just a little bit. Certainly from a policy perspective, it's challenging. One thing we're doing is price transparency. So we have an all-payer claims database. Okay, lots of states do, but we're kind of revamping it. We just revamped it, and we're putting in more prices so patients can shop for care. Most people are in a high deductible health plan, right? And most of you are probably in a high deductible health plan. You need to be able to shop for care. We're going to have uninsured, underinsured in the Medicaid population. They need to be able to shop for prices. So we are loading up the tick file data that match the transparency and coverage, negotiated prices, and a bunch of other price transparency, and quality transparency, ownership transparency, just a lot more transparency to empower people so they can shop for care.
Thank you. Well, thank you to both Kate and to Gloria. This has been excellent.